Assemblyman Jim Wood is the chair of the Assembly Healthcare Committee, and I am just tremendously proud that he is here. He's one of the more thoughtful policymakers of any state in which we work, and I think is one of the more understated but one of the more important driving forces in healthcare policy in California. Let's please give him a round of applause and welcome him to the stage. Sir? Thank you.
Thank you. I use my least favorite place in life, a podium, for a minute here. Just to have some opening remarks, and then actually what I really am looking forward to is just an interaction with DJ and hearing from you as well. So thank you very much for the opportunity to be here this morning. I know this is quite an impressive group, all coming together to talk about healthcare and how we can get it to everyone who needs it. Your agenda is also impressive, and it looks like you're going to hit on just about every important aspect of healthcare in your meetings today. I'd like to begin the morning by making just a few general comments about what, as chair of the Health Committee, the legislature has, that I see, and the legislature has been challenged with the past few years, and then I'm happy to see what DJ dreams up to ask me. Providing health care to all who call California home has been a goal of mine since I was first elected almost 5 years ago. It's certainly been a hot topic at a national level as well, especially as we entered the presidential campaign. All right, we've already begun the presidential campaign, and it's only a short 544 days to go, which is a little bit frightening, quite frankly. On a more positive side, we have a new governor who has made healthcare one of his priorities and has certainly spoken about it regularly. I've also appreciated his understanding that we cannot reach the goal of healthcare for all with the single stroke of a pen on a single bill. So I'm looking forward to having a partnership with the governor and his advisors on this important issue. So what have we been doing the last few years over across the street? Well, 2 years ago, our Assembly Speaker, Anthony Rendon, put together a select committee to bring experts and elected officials from all over to share their research and life experiences on improving healthcare delivery systems, and I was a co-chair of that select committee. And what we learned after 30 hours of expert testimony and 5 months of hearings was published in a report in early 2018 with actionable recommendations to move us forward. Many that became a combination of legislation and budget asks last year. Some of those proposals required significant funding, and although we were able to make some progress, we didn't win them all. Some are back this year, and I'll talk more about that in a minute. The report of the Select Committee also acknowledged the challenges of combining care in one system. Legal and constitutional issues that must be addressed, the importance of a strong primary care system, developing a benefits package, provider payments that reward better health outcomes, a stronger social safety net, and administrative simplicity. Although some people didn't like the findings of that report, it's not surprising to me that the Congressional Budget Office published in its assessment of Medicare for All and validated much of what our Select Committee already found. If we didn't know it before, we know it now. Healthcare is complicated, and the public is beginning to hear about those complications as we listen to presidential candidates and talk about Medicare for All. When you look at the 30,000-foot level, first, what is the definition of Medicare for all? Second, what are the benefits? What are the benefits? Are they built on what we need or what we want? Third, how do you transition to it? What are the barriers that stand in the way? And finally, how do you pay for it? And who pays for it? Everyone needs to understand these basic definitions. And unfortunately, a lot of that seems to get lost in the rhetoric sometimes. Although we could spend the entire time talking about that, I'd also like to talk about what we can do now to get care to more people and contain costs. Because if we don't contain costs, I think you heard that already, we'll never be able to afford coverage, to provide coverage, and more importantly, care to everyone. The ACA has made great progress in California and with regard to reducing the number of people that are uninsured, but there's more that we can do. Here's some of the legislation and budget asks we've put forward in the past 2 years, as well as this year. Last year, we received funding to build an all-payer payment database, claims database. and funding for a council to develop a pathway to a unified publicly financed system for healthcare for all. I can't even say it, it's so complicated. We also are looking to provide enhanced premium assistance to individuals and families enrolled in Covered California by using tax credits and increased subsidies. That's part of a bill I'm running this year, AB 174. We want to increase the number of people eligible for coverage or assistance by expanding it to people with incomes in the 400 to 600% of the federal poverty level, a group of folks that are making a good living, but they're just having a really difficult time affording the cost of health care. We want to help aged and disabled people from suffering the indignities of having to worry about whether they pay rent, buy food, or see a doctor. We have a bill related to a little-known home upkeep allowance that would help a small group of seniors there. And we'd also like to make sure that we can get rid of what we call the senior penalty, how some people lose their Medi-Cal benefits simply by turning 65. We want to fight the high and often unwarranted costs of pharmaceuticals, with these costs directly affecting the cost of care to people and people's premiums. We have to find ways to affect this market and their practices. A couple years ago, SB 17 by Dr. Hernandez focused on transparency of drug prices. We had a bill relating to coupons in 2017 as well. Last year, I had a bill related to oversight of pharmacy benefit managers. And then this year, a bill I'm working on, AB 824, which looks at stopping what we call pay for delay, a process that keeps generics from getting to the market when they should. And that's, in my opinion, that needs to end. We need to plan for an aging population. The only segment growing significantly in California is our older folks. Vulnerable seniors will require more care as our healthcare professionals retire. We don't have enough primary care physicians to provide that care. By next year, I believe, we're looking at a shortage of about 4,000 primary care physicians in California. And a lot of folks are just simply not moving to rural communities. We want to maximize the use of our healthcare professionals. I was recently a commissioner on the California Healthcare Foundation's Healthcare Workforce Commission, and one of the top priorities coming out of that work is to allow nurse practitioners to practice to the full extent of their scope without the oversight of a physician. My bill this year, AB 890, would allow just that. Expanding the use of technology for rural and other underserved areas. This can also improve access to mental health services. I've made a budget ask around e-consult development as a pilot project. And as hospitals and health plans and pharmaceutical companies combine, we need to assure that the primary beneficiaries of these mergers are consumers, not we're actually helping patients in the long run. And by that, last year we had a bill that actually gave us the opportunity to really look at health plan mergers to see is that really appropriate. So before I join DJ for discussion, let me put out there some examples of how we're challenged to make healthcare more affordable. It just gives you a little more insight into the difficulties we have as legislators that we face every day. As you may know, we have legislation moving this year to reintroduce the mandate, the individual mandate at the state level. Logical, right? We all know it's integral to making the ACA work, and it was removed through the actions of Congress and the Trump administration. I refer to some of these actions as death by 1,000 cuts. So far not fatal, but sometimes we feel like we are bleeding out. The challenge comes when we decide how to implement the mandate again. We want it to be a carrot for choosing coverage, not a stick by paying the penalty. Yes, those funds collected could be used to increase subsidies and even increase the number of people who qualify for subsidies, but can we get to a place where buying coverage is more desirable than paying the penalty? I certainly hope so. We have legislation before us asking to add coverage for additional benefits, which will ultimately add costs to our system. I'm not here to opine on which benefits should be added or not added, but and what's considered necessary versus preferred. But it's an example of how, when we try to reduce costs, how difficult that can be. Other examples of challenges before us: the issues of hospital seismic retrofits. We have a bill up before us that would require the owner of an acute inpatient hospital where the building does not substantially comply with the 2030 seismic safety standards, to report the services provided in each building of the acute inpatient hospital by updating an existing submission to OSHPD. Why the bill? Because having that information may help OSHPD implement existing seismic safety regulations and standards by understanding the impact that closing a hospital may have if it cannot meet the 2030 deadline. For instance, in my rural district, I have 3 hospitals that are facing retrofit challenges, one in Fort Bragg, one in Garberville, and one in Weaverville. These are not big communities. Weaverville is about 4,000 people. Garberville is about 2,000 people. Fort Bragg's the monster of the 3. It's about 5,000 people. These are not big communities. And so the challenges of retrofitting, seismic retrofit, which could be 50 plus $100 million, could be really, really difficult. So as we go forward, we want to be sure that we're actually doing the right thing, and that the impacts of losing a hospital and community are significant. In my case, in these closing one or even one of these hospitals could mean that someone would have to drive a couple of hours to get to another hospital, and that's really difficult to do in our world. So without taking a position on the examples, although I kind of did, I just posed them to show how we have difficult choices we're faced every day. We try to make healthcare more affordable. We're trying to increase access to care, consider benefit requests for additional benefits, and look at providing adequate reimbursement rates in our society and our social safety net. It's suffice it to say, things are really complicated, and I look forward to the questions. I really hate standing at a podium, so for that, DJ, come rescue me from the podium.
Thank you, Assemblyman. Appreciate it.
You're gonna sit down, huh?
Yeah, well, that way you don't have to wrestle with the podium.
Okay, good.
Let's sort of start first and shift gears and have you tell us about your district and the people there.
Wow. I have the largest assembly district of any Democrat in the legislature. So it takes me about 7 hours to get from one end to the other. It starts in the middle of Santa Rosa and goes to the Oregon border. It also includes Trinity County. So it's an enormous district. And each region of that district is different. I say often, with affection, that it is like having 5 children from 5 different mothers. It really is. We have very progressive to libertarian to very even more conservative.
Yeah.
And it's a challenge to try to serve the needs of all my constituents.
So give us a sense of the caucus dynamics. As you know, the Democratic caucus is very progressive. It's very urban. It's got a lot of people of color, and you're a white man from the sticks, which I say lovingly.
Wow.
How you become a strong advocate for rural issues that might, I think, otherwise get left behind without your voice, I think.
Well, I think it really goes back to my roots. I practiced dentistry in a small community in Sonoma County called Cloverdale.
Yeah.
And when I got there in 1987, it was 3,600 people. It's now about 8,500 people. So it's not, 30 plus years, that's not a huge amount of growth. But
Yeah.
what I saw firsthand was the real challenges we face in rural areas. A lot of urban areas, there's, and the numbers are not perfect, but you use it as an illustration. About 95% of people live on 5% of the land mass in California. And 5% live in the other 95%. And that's kind of my district.
Yeah.
So it is challenging there. But for me, the roots of it are, how could I get the best care to to the people that I served? And that's what got me interested in healthcare policy. And that's ultimately what led me here.
Yeah, I think sometimes in Sacramento we can focus too much on what happens inside the building and forget that there are people back home counting on y'all. So I wanted to give you an opportunity to sort of talk about them a little bit. And in that vein, I had heard a story, and tell me if it's incorrect, but I had heard a story that the wildfires have hit your district hard, and that you were regularly going and providing dental care and just helping in a range of ways. What was that like for your district, and how were you personally involved?
The fires were particularly devastating. Ironically, the day that the governor signed SB 17, the drug transparency bill, was the morning after the fires started in my district. And so I was at the signing for that bill and then was back in my district for months, essentially. The fires were absolutely devastating, and overall, the fires in between Mendocino County, Napa County, Sonoma County, 44 people died, and so we made up a bunch of things on the fly, trying to provide resources to people, trying to help people match up with their needs, and it was a challenge. And then I do forensic consulting for the sheriff's department. So part of what I did was help to identify the victims there, and which is sobering. When you see people from streets that you know, and nobody that I knew personally, but that was difficult. But we also kind of created a template. We didn't expect to, but we didn't expect the rest of the fires to happen. We didn't expect what happened in December. We didn't expect the fire in Reading last summer, and we certainly didn't expect the campfire. So part of what has become a role for me has been working with my colleagues who have now, too many of us have had to experience those fires, and the ramifications of that have been really, really broad.
Yeah, thanks for sharing that. It wasn't dental care, it was the forensic analysis that I had heard. That's a powerful story. Shifting gears back to the legislature, tell me, how would you, it's always hard for a first year governor to get his or her team in place, and it's not the year you'll see a lot of ambitious legislative proposals in the first year usually. How would you sort of characterize the Newsom administration getting its feet underneath it on health policy to this crowd that is not always in the building, so to speak?
Well, I have to say I'm impressed. I was impressed from the beginning in the inaugural address, and where he talked about health care. He talked about it a lot when he was running. It was not a priority for the Brown administration. I mean, if there's anybody in here who doubts that, I've got a lot of statistics to show that it was not, but it appears to be. And as you see the budget going forward, there is money there for things that we haven't seen in the past. I think what's been, it is a new administration, so there are starts and stops, and it is difficult to put together that team. But I see the team coming together, and there's some really great people who have a lot of healthcare knowledge there, and it's really encouraging to people like me. So we'll see going forward.
And how would you characterize the flip side, not the inside state government, but outside in the advocacy community? I sort of wonder how much the progressive advocacy community is willing to wait and let things develop because they know that's required right now, or how much are they chomping at the bit with the new administration to really push through more progressive proposals? Those conversations come into your office. How would you characterize the willingness of the progressive community to be patient?
Well, I'll be honest. From last session, there wasn't a lot of patience, and I am data-driven by nature. I have a science background. I'm data-driven. I've always lived of the measure twice, cut once. I really want to understand the ramifications of what it is we're looking to do. And for me, I think it's been grossly misinterpreted, my attitude about how I want to see healthcare develop in this state, is that because I am cautious, I do want to make sure that we don't make mistakes that create bigger problems for us down the line. So I have been an advocate for, let's look at the data, let's really figure this out, and let's get the pieces in place before we jump into the deep end. And I know that frustrates people, but I will tell you, it is really, really difficult to move policy in the building. There are a lot of entrenched interests that thrive on the status quo. And even simple things are really hard to do, and I don't think people really understand that.
Yeah. Sometimes folks, let me ask you to respond to a statement that I've heard occasionally, which is from an old Republican legislator that said, "The enemy is not the Democrats. Remember that. The enemy is the other chamber.
Yeah, the Senate.
Yeah.
Yeah, that's how we look at it.
Yeah.
Actually, quite honestly, sometimes the enemy is the Department of Finance.
Yeah.
They're the Department of No.
Yeah.
You know? That's extremely frustrating. And I say that because the way our budgets and everything work here, everything's a line item. And so we don't invest in things. Everything is looked at on a year-to-year basis. And so if you're really trying to make a change in healthcare policy, you're trying to change the needle, you want to push things that are going to do more for prevention and that are ultimately going to save us money, the Department of Finance doesn't look at it that way. Oh, it's going to cost us money this year, therefore we can't do that.
Yeah.
And it's really frustrating.
Yeah, I bet. Why don't you first tell us your name and your organization and fire away.
Yes, I think the Assembly member knows me. Dale Fountain with Enact Universal Healthcare for California. You talked about finances, and I think that's a really great thing to worry about. One thing in particular that you pushed for, or at least incrementally, was a public option. Now, with the state fund, State Compensation Insurance Fund, that's the largest insurance company in California and state-owned. They do workers' comp, but it's also health insurance, the most catastrophic kind. How about opening that up to a public option that people can buy into? That would cost the state nothing itself, since that would be run by a state fund. What do you think about that?
You know, it's an interesting concept. I hadn't really thought about that, quite frankly. I know that it is, you know, we are looking at trying to figure out a public option, and certainly I think we should put everything on the table. But I'll look forward. I'll look more at that. But I hadn't really thought about it much, so quite frankly.
Good morning. My name is Bob Beltran. I'm with Brand New Day Health Plan. We're a chronic special needs plan, and our flagship plan is a plan takes care of the severely persistently mentally ill, and we've had it since the 80s. So my question to you is, what's going on with mental health care in the state of California?
That's a great question. We actually had a couple of informational hearings with the joint hearings with the Senate last month on mental health care. What's working well, what isn't working, and the challenges we face there. And we have learned a lot. We are taking back information and asking a lot more questions. I think that one of the biggest challenges we have with mental health care is a lack of providers. And that means that we need the resources to support the training of providers and actually the retaining providers. I was shocked, and I sit on the budget subcommittee for Health and Human Services, and when we look at all the budget asks and things, and these are long hearings, but I'll tell you, you learn a lot. And it's shocking to me that our state hospitals, psychiatric hospitals, where some of the sickest of our folks are, the vacancy rate for psychiatrists is over 40% in the state hospitals, and that's a challenge. So we face, I believe, one of the biggest challenges we face with delivering behavioral health care to people is workforce, and it is across the board, and it's something we absolutely have to address. And it was a big topic through our Healthcare Workforce Commission report. We broke it into, mental health was one of the sections that we looked at, and we absolutely recognize that we need to do a much better job with workforce.
Let me ask a question on that before we go
Yeah.
back to this audience question. I read an interview with Jennifer Kent in preparation for an interview we'll do with her shortly, and she said that she believes strongly that behavioral health integration, mental health integration into physical health required a constitutional amendment. It was her view that the carve-outs that, and I haven't read the Constitution in this part to know, but her comment was that the previous realignments have essentially codified in the Constitution that mental health it goes through the counties. Mm-hmm. Is that your understanding, that it takes a constitutional amendment to sort of integrate behavioral health, or is that, it was news to me?
Well, that's kind of shocking. It shouldn't, It's like saying, well, do we need to do that for dental health too, or chiropractic? I don't know. That's a very, very interesting. I haven't heard that, but I'm gonna think I need to have coffee with Jennifer and talk about that a little bit more.
Yeah, it was the first time, and in her defense, I haven't been able to directly ask her either, but I hadn't heard that. I thought I'd get your thoughts there. Did I see a question here?
Diana Livingston, DSR Health Law. I know that either last week or the week before, that Governor Newsom did the Healthcare Delivery System Reform Committee, which I believe you referenced earlier, and is transferring those funds over to Healthy California Committee to specifically study single-payer reforms. Is that correct? First of all, am I following that correctly? And second of all, what does that mean in terms of research that the legislature and the governor will be doing into a variety of delivery system reform options?
Well, that is, the governor has, through a trailer bill, introduced language that would refocus the commission that was established in the last budget by Governor Brown. It would expand from 5 to 13, and it is his desire to focus that entirely on single payer. So at this point, because it is part of the budget negotiations, I'm not sure exactly where that's going to go. I know the Speaker of the Assembly is not happy. He would prefer it to be broader and more all-encompassing. So we will see where that goes. It's a part of the negotiations. But the idea is to make it broader as far as the membership, but focus it more on single payer, and we'll see where the discussions go. I applaud that making it broader. I think more people there is helpful, more expertise, and I look forward to the discussions.
Other questions out there? Over here? Great.
Good morning. My name is Sammy Chang. I'm part of the Source on Healthcare Pricing Competition, which is part of the UCSF and UC Hastings Consortium on Law, Science, and Health Policy. That was very long. But I wanted to ask about merger review. I really appreciate your bill last year, AB 595, which increased merger review. But in the face of increased consolidation of insurers, hospitals, provider groups, and other medical professionals, what do you think is next for California in terms of merger review authority?
Well, and that's a great question. I think I think if bigger is truly better, we need to be sure that it is, and that's kind of the purpose of a review. I think for me, we have a bill we introduced this year. We're going to work on the details of that through next year, but it's around hospital merger. And hospital system mergers. We're working with the Attorney General's office on that. I think that is, once again, we want to be sure, are these mergers actually going to be, do two things: provide higher quality care and not be onerous to consumers, actually to improve the finances for consumers as well. And so that's going to be a really complicated topic. And I look forward to that and just learning more about it. The system is so complicated. One tweak in one place creates huge potential challenges, and that is I believe hospitals will be the next one we really look at.
Let me ask you a follow-up there. I think there's pretty broad consensus, maybe not with the hospital association, but pretty broad, I think, opinion that looking at consolidation in a future forward-looking way makes some sense. Mm-hmm. What do you think about looking at consolidation that's already occurred? And let me start there, but let me ask this sort of parallel question, which is there was a study out that we will be featuring here in part later this afternoon by Stephen Shortell at Berkeley that said every county that has a hospital in it has monopoly or monopoly-like market leverage. Every single county, the rural county and LA County. And post-ACA, we've seen a lot of consolidation that appears to have been, in many cases, created some market leverage for pricing. Usually when we have, and that's just the market sort of working as the market does, but when the market has done that in the last 100 years, electricity and railroads and some of these things that we consider important, we've taken those sectors and regulated them like crazy, like public utilities and again, railroads. So for the backward-looking consolidation, do you think it makes sense to move closer towards this sort of public utility kind of model, even for private hospitals or private entities where they have market leverage that might, that does impact pricing and costs in the system?
I think some people would argue we already are headed in that direction with just the nature of how much, how the payer mix out there. Interesting question. Hadn't thought about that.
Yeah.
But I'm open to looking at everything at this point.
There aren't a lot of folks out there who are excited about rate review, or rate setting, but that's sort of part of the conversation there.
No, what's interesting, and you talked about this in your opening comments about cost containment being and people don't like the word cost containment, so other people have morphed into saying affordability. And I think that we actually have to come to grips with the fact that the cost of healthcare is the rate of cost increases is twice inflation, and we cannot continue to sustain that. And the challenge that we have with the legislature across the street is that anytime you try to tweak something or impact that, it's like a little nuclear weapon went off somewhere, because there is huge resistance to anything that would contain costs somewhere. So you try to focus on what some people say, well, that's a minor thing. But if you can't even get the minor things done, how do we address this globally?
Yeah.
And it's really, really difficult to have these discussions. But if we are truly going to make healthcare more affordable and provide real care to people, and make it sustainable, we have to have those discussions, and they're difficult discussions.
Over here.
Yeah, good morning. My name is Tina Buop. I'm the Chief Information Officer in Managed Care. My question is around privacy and security. I used to co-chair the privacy and security team with Cal Ojai, and in the Schwarzenegger administration, we had a lot of support with the intent of harmonizing all of the HIPAA laws and the goal to provide education and information to the physician and provider community. What, if any, legislation or organization or advocacy is happening right now or planned to happen to help encourage that type of information propagated to the physician and the practice community for any type of privacy and security change?
That's a good question, and I will tell you as in health committee, we don't see a lot of privacy issues coming forward. We do have a specific committee related to privacy in the legislature, and so there may be more there. But it is a growing concern. There's more and more information is out there, and how do we protect that for people? But they're really, I'm not aware of anything. The privacy is typically related to a specific, sometimes a product or a service or whatever. It's a little, when we're talking about it in my committee, it's less global and more specific to a bill or a concept. So, but the more global conversations around privacy are happening in another committee. So, but they're real, they're serious, and they're real.
Hi, George Baltieri with Quote Selection Insurance Services. I was wondering for the, you alluded to the carrot and the stick at the beginning of your talk, and I was just interested in hearing some commentary on what you think the likelihood or how the discussions are going on those two areas. In other words, the mandate and the expansion of the FPL limits.
I think we're going to find out fairly soon so we're in kind of a weird little window of time right now where the bulk of the bills have been heard in policy committees. We're still meeting on budget subcommittees and working through that. But at the end of next week, a week from today, the Appropriations Committee will release whatever bills are going to move forward this year. So I think that will kind of set the stage for what happens for the rest of the year. I do believe that the affordability bills will move forward. I think I think we'll definitely see that. I believe the mandate bill will move forward, but then the battle comes on the floor. It's difficult. People don't. I think the individual mandate was one of those things that was not popular in when these discussions happen. And oddly enough, a public option in D.C. was really hotly debated when the ACA came to be. So it will be interesting discussions, but Covered California believes, and I believe, that it is critical that we have the mandate going forward. The more people we have in the pool, the better. And as we transition to something different in the future, we can't just abandon everything now. I think the goal, my personal goal, is that we get more and more people covered as we move to a different system in California, something I hope will be uniquely Californian.
My name's Deborah Madden, and I'm with California Healthcare Conversations. And my question relates to the cost containment or affordability on the individual and small business markets. You comment on you being data-driven and that it's very difficult to even get small changes through. But when you're looking at people who really have issues with healthcare security, meaning high deductibles, and not only the high deductibles, but the overall question of whether they're going to have to look at their employment issues through a filter of healthcare. What can you do to assure those people that despite being data-driven and despite the difficulty of getting things through, they're going to have some relief with the cost containment, not just the premiums, but also the other issues? It's still very expensive with their out-of-pockets, with their 20% contributions on, say, medical devices. Despite those difficulties and time pressures, what can be done?
Well, and that's the battle I fight every day. And I thank you for that question. That is the battle I fight every day. I look at, for example, AB 824, a bill I have that's looking at these pay for delay agreements that happen between large brand name drug companies and generics to keep the generics off the market. There's so many things out there that are happening that keep the cost of healthcare high, and it's frustrating. And for me, it is part of this is, we have a lot. There's profit. So many of these companies are for-profit companies, and so I don't demonize them personally as people running these, because their job is to make money for their stockholders and for the company. But what it does is makes life difficult for all of us. And so if we can make some inroads on some cost containment things, I believe that opens up the door for others. And I think that's why we're being fought so hard on this, because I think everybody wants cost containment, but I don't want it contained because on me. I want it on the other guy. And so at some point we all have to accept that everybody needs to have a little skin in the game here if the goal is to have a system that is not going to completely implode, which it feels like it's going to at some point. So I'm just going to keep fighting the fight and trying to make inroads there. I just feel like if we can make some inroads, we're going to open the door and make it easier for the next wave. And I think that's why we're being fought so hard. And that's a challenge I welcome, quite frankly.
I will say that, as I said at the beginning, I think that I just think you're a tremendous force in the legislature, and I appreciate all the work that you do. I know some people in this very polarized and expectant and anticipatory time. People want to move quickly, and I think that your approach not only gets you a lot of respect from your caucus members, it gets you a lot of respect from your speaker, but gets you a lot of respect from the enemies on the other side of the chamber or in the other part of the building. So as a policy geek, I appreciate it. As another white guy from the sticks, I appreciate your perspective. And let's give Assemblymember Wood a round of applause.
Thank you.
Thanks, sir.
Thank you very much.
Thank you very much.
Thank you.
Appreciate it.
Thank you.